The call comes in the morning. Someone went to bed the night before, feeling fine, watched television, said goodnight, fell asleep, and by the time the sun came up, they were gone. No warning, no chest pain anyone knew about, no ambulance called in the night, just a person who went to sleep and did not wake up. We call it dying in your sleep, and there is a reason people say it, like it is peaceful, like it is the gentlest way to go. But what nobody tells you is that for the heart, the overnight hours are not peaceful at all. They are, for a significant number of adults, particularly adults over 60, the most dangerous hours of the entire day. Between 2 in the morning and 6 in the morning, cardiovascular events are disproportionately common. Heart attacks, strokes, sudden cardiac death. The research on this has been consistent for decades. It is not random timing. It is biology. There are specific things that happen to the body during sleep, things that can be made dramatically worse by habits practiced every evening without a second thought, that turn the overnight hours into a window of elevated risk. The reason I am making this video is not to frighten you. It is because most of what drives nocturnal cardiovascular risk is modifiable: the evening meal, the last drink before bed, the temperature of the room, whether the airway stays open through the night, whether blood pressure is being managed in a way that accounts for what happens after midnight. These are not abstract medical variables. They are decisions made between dinner and lights out every single night, and most people making them have no idea they matter. Before I say anything further, what I share here is educational information only, not medical advice. Nothing in this video replaces an evaluation by your own cardiologist or primary care physician. If you have existing cardiovascular conditions, please always speak with your healthcare provider before making changes to your evening routine or your medications. What I want to give you today is the understanding to have that conversation with far more clarity than you may have had before. Stay through to the end, because the final thing I want to share, the simple evening routine that takes less than 10 minutes, is the part that ties everything together into something you can actually use tonight. I am Dr. Andrew Carter, 15 years working exclusively with adults over 60. I have sat with families after exactly the kind of morning I described at the start of this video, and I have sat with people who came to me asking how to make sure they do not become that story. The difference between those two conversations is knowledge. The habits that elevate overnight cardiovascular risk are not rare. They are common, and they are correctable. If you are watching this channel for the first time, subscribe right now. Every week I bring this level of information about what is happening inside the body after 60 because you deserve to understand it. Let me start with what actually changes inside the body overnight, because this context makes everything else make sense. During normal sleep, the autonomic nervous system shifts. The parasympathetic branch, the one associated with rest, digestion, and recovery, takes over from the sympathetic branch that drives alertness and stress response. Heart rate slows, blood pressure drops. This drop, called nocturnal dipping, is healthy and expected. In adults with a well-functioning cardiovascular system, blood pressure falls by somewhere between 10 and 20% during sleep. But two things interrupt this pattern in the early morning hours. The first is a process called the cortisol awakening response. As the body prepares to transition from deep sleep to waking, the adrenal glands begin releasing cortisol in the hours before dawn. Cortisol raises blood pressure. It activates the sympathetic nervous system. It increases the stickiness of blood platelets, making clotting more likely. All of this is preparation for the demands of the waking day. But it is also, in a cardiovascular system already under stress, a loaded gun in the early morning hours. The second is that in adults who do not dip adequately overnight, those with untreated sleep apnea, with poorly controlled blood pressure, with certain medication patterns, blood pressure can actually climb during sleep rather than fall. A pattern called non-dipping, where nighttime blood pressure equals or exceeds daytime readings, is associated with significantly higher rates of cardiac events, stroke, and end organ damage than standard daytime hypertension. A study published in the Journal of the American Heart Association found that non-dipping blood pressure patterns were associated with a 2 to 3 times higher risk of major cardiovascular intervention compared to normal nocturnal dipping, independent of average blood pressure levels. 2 to 3 times, not from a disease, from a pattern that is often invisible without a 24-hour ambulatory blood pressure monitor, a test most adults with hypertension have never had. Understanding this landscape, the cortisol surge, the platelet activation, the blood pressure shift, is the foundation for understanding why the 5 habits I am going to walk you through do not just make you feel mildly unwell in the morning. They stack on top of a physiology that is already at elevated risk during those specific overnight hours. The first habit is one that probably half the people watching this video practice regularly, often without recognizing the cardiovascular dimension of it at all. Eating a large meal within 2 to 3 hours of going to bed. When a large amount of food, particularly food high in fat, refined carbohydrate, or sodium, is consumed in the evening, several things happen. Triglycerides rise in the blood. Their elevation after a fatty meal is normal and temporary under most circumstances. But when that elevation occurs in the evening and the person lies down within an hour or two, the blood becomes more viscous at exactly the time when blood pressure is beginning to shift and the early morning cortisol surge is a few hours away. Sodium consumed at dinner raises blood pressure, and its effect peaks not in the hour after eating, but over the subsequent 4 to 6 hours. A salty meal at 8 in the evening has its strongest effect on blood pressure between midnight and 2 in the morning. In an adult whose heart is working overnight without the supervisory adjustments of waking consciousness, that sodium-driven pressure spike is not something they will feel. It is something their cardiovascular system will absorb silently. There is also the mechanical dimension. The recumbent position increases intra-abdominal pressure on a full stomach. That pressure can push digestive acid upward into the esophagus reflux, which activates the vagus nerve and can trigger arrhythmias in susceptible adults. There is a well-documented connection between nocturnal acid reflux and atrial fibrillation episodes, the same nerve running alongside the same structure, responding to the same irritant. A study published in the European Heart Journal found that eating within 2 hours of sleep was associated with significantly elevated overnight blood pressure and higher rates of non-dipping patterns, with the association strongest in adults over 55. The practical change here is not about eating less. It is about eating earlier. Moving the main meal to before 6 in the evening or at least 3 hours before sleep gives the body time to process that metabolic load before the critical overnight window opens. That gap matters more than most people have been told. The second habit is discussed in terms of sleep quality, but almost never in terms of cardiac risk. And for adults over 60, the cardiac risk may be the more urgent conversation. Going to bed even mildly dehydrated. Blood is approximately 90% water. When the body is short on fluid, even slightly, even in a way that produces no conscious sensation of thirst, the blood becomes more concentrated. Thicker blood moves more slowly through smaller vessels. It takes more effort from the heart to push. It is more likely to form clots when it encounters vessel walls, particularly in coronary and cerebral vessels where flow is already slower overnight. And it responds more dramatically to the platelet-activating effect of the cortisol surge before dawn. The thirst mechanism in adults over 60 is genuinely less sensitive than it was at 40. This is not a complaint. It is a physiological change that is well documented. Older adults can arrive at bedtime in a state of meaningful fluid deficit without having felt thirsty through the afternoon. A study published in the journal Circulation found that adults who maintained good hydration had significantly lower rates of cardiovascular events over a 5-year follow-up, with the association particularly pronounced for nocturnal events consistent with the elevated clot risk during early morning hours. The practical approach is not to drink large volumes at bedtime that disrupt sleep through nocturia. It is to front-load hydration through the day so that by early evening the body is already in adequate fluid balance. 6 to 8 cups of water during the day with attention to replacing any fluid lost through coffee or physical activity means arriving at bedtime already hydrated. A small glass of water before sleep can assist without significantly disrupting continuity. Alcohol deserves specific mention. Many adults over 60 believe a drink in the evening promotes sleep. Alcohol does reduce the time to fall asleep. It also fragments sleep in the second half of the night, suppresses deep sleep stages, and acts as a diuretic, contributing directly to overnight fluid deficit. A study published in the British medical journal Open found that moderate evening alcohol consumption was associated with measurable increases in next morning cardiovascular risk markers, including elevated platelet aggregation and morning blood pressure in adults over 60. The relaxation felt during the drink is real. The downstream cardiovascular effects are also real, and they arrive while the person is asleep. The third habit is the one I find most important to discuss, not because it is complicated, but because so many people have been living with the underlying condition for years without knowing it. Sleeping with untreated obstructive sleep apnea. Sleep apnea is a condition where the airway partially or completely collapses repeatedly during sleep. Each collapse causes a drop in blood oxygen. The brain, detecting the drop, sends an emergency signal that jolts the body into a partial arousal, enough to restore muscle tone in the airway and restart breathing. This can happen 5 times per hour. It can happen 50. Most people have no memory of any of it. They simply wake up tired with a dry mouth, sometimes with a headache, wondering why 8 hours of sleep does not feel like 8 hours of sleep. What is happening to the heart during each of these events is the question that matters. Every apnea episode produces a surge of sympathetic nervous system activation. Adrenaline, cortisol, heart rate spikes, blood pressure can jump by 30 or 40 points during severe events. The arterial lining is exposed to repeated oxidative stress. Inflammation markers rise. Over months and years, this accumulated nightly stress produces measurable structural changes. The left ventricle thickens, arteries stiffen, atrial fibrillation becomes significantly more likely, and blood pressure that is controlled during the day becomes uncontrolled at night. A landmark study published in the New England Journal of Medicine found that untreated severe sleep apnea was associated with a nearly 3 times higher rate of fatal cardiovascular events compared to adults without the condition. Among those events, a disproportionate number occurred during sleep during exactly the window when the apnea events themselves were most frequent and most severe. The most important point here is not about the treatment, it is about the diagnosis. The majority of adults with clinically significant sleep apnea have not been diagnosed. They have been told they snore, they have been told they are tired because they are getting older. Meanwhile, the overnight cardiovascular stress accumulates night after night without a name, without a treatment, without the monitoring it warrants. If you snore loudly, if you are told you stop breathing during sleep, if you wake with a dry mouth and a headache, if you feel genuinely tired, regardless of how many hours you sleep, ask your doctor for a sleep study. A home sleep test is done in your own bed, non-invasive, with results typically available within days. A positive result leading to appropriate treatment produces among the most dramatic improvements in cardiovascular risk profile of any intervention I have seen in adults over 60. Type yes in the comments right now if you snore or wake up tired consistently and have never been evaluated for sleep apnea. That yes may be the most important thing you type today. And if you are not yet part of this channel, subscribe right now and ring that bell. Every week I come here to give you information that has the potential to change your health in a real and measurable way. I want to tell you about William, 67 years old, retired firefighter from Dallas, Texas. He came to me not because he was worried about his heart, his last cardiac checkup had been unremarkable, but because his wife had watched him stop breathing on 3 separate occasions for what felt like 20 to 30 seconds during sleep. His daytime blood pressure on medication was consistently around 128 over 78. His doctor was satisfied, he felt fine. I asked for a 24-hour ambulatory blood pressure monitor. His daytime readings were exactly as expected. His overnight readings between midnight and 5 in the morning were averaging 158 over 94. He was a non-dipper. His pressure was not falling during sleep. It was rising significantly during exactly the hours when he was having apnea events. A home sleep study confirmed moderate to severe obstructive sleep apnea, 34 events per hour on average. 8 weeks of CPAP therapy later, his overnight blood pressure had normalized. The morning headaches he had attributed to aging resolved. His wife told me he had become a different person to sleep next to. More importantly, the cardiovascular risk that had been building silently in the overnight hours, invisible to every daytime measurement, was finally being addressed. He had been told for 2 years that his heart health was fine. His heart health was only fine between 9 in the morning and 10 at night. The fourth habit seems too simple to matter, and that simplicity is exactly why most people never change it. Sleeping in a room that is too warm. The body's core temperature naturally falls during sleep as part of entering and maintaining deep sleep stages. This temperature drop is not just a symptom of sleep, it is a driver of it. The cooler the body gets, the more reliably deep sleep occurs. And deep slow-wave sleep is the stage most associated with cardiovascular restoration, the period when heart rate is most stable, blood pressure is lowest, and tissue repair is most active. When the sleeping environment is too warm, above approximately 68 to 70 degrees Fahrenheit, the body struggles to shed the heat it needs to lose. Peripheral blood vessels dilate, attempting to radiate heat through the skin. The heart works harder to circulate blood to the skin surface. Sleep becomes lighter and more fragmented. The nocturnal blood pressure dip is reduced or eliminated, and the restorative cardiovascular work that deep sleep is supposed to accomplish does not get done. In adults over 60, thermoregulatory efficiency is reduced. The ability to shed heat during sleep is less reliable than at younger ages, which means the consequences of a too warm room are more pronounced. The cold extreme carries its own risks. A sleeping environment below approximately 60 degrees can trigger vasoconstriction, peripheral blood vessels narrowing to conserve heat, which raises blood pressure and increases cardiac workload during the already elevated risk early morning hours. The cardiovascular sweet spot for sleeping temperature is between 62 and 67 degrees Fahrenheit, with appropriate bedding for warmth rather than relying on room temperature. A study published in the journal Heart found that adults who maintained cooler sleeping environments had significantly lower rates of nocturnal blood pressure elevation and more consistent nocturnal dipping patterns than those sleeping in warmer rooms, even when medications and exercise were controlled. A thermostat adjustment, operating directly on the cardiovascular physiology of sleep, consistently underutilized. The fifth habit brings everything together because it sits underneath all of the other risks and amplifies each one. Going to bed with blood pressure medication timed in a way that leaves the early morning hours unprotected. Blood pressure medication is typically prescribed once daily, most often in the morning. This pattern made clinical sense for decades based on daytime measurements, but it does not account for the non-dipping pattern, the cortisol surge between 2 and 6 in the morning, or the period of highest cardiovascular event risk in those early hours. A study published in the European Heart Journal, one of the largest chronotherapy trials in cardiology, found that adults who took at least one antihypertensive medication at bedtime rather than in the morning had significantly better overnight blood pressure control, more consistent nocturnal dipping, and a 45% lower rate of major cardiovascular events over more than 5 years of follow-up, 45% lower, not from a different medication, not from a higher dose. The same medication, moved to bedtime. Most people take their blood pressure pill in the morning with their other medications and never consider that timing matters. For many adults with well-controlled daytime blood pressure who still experience nocturnal non-dipping, the timing of their antihypertensive may be the single most impactful change available to them. Raise this specific question at your next appointment. Ask, based on my blood pressure pattern, would there be a benefit to taking one of my antihypertensive medications at bedtime? And if you have never had a 24-hour ambulatory blood pressure monitor, ask your doctor about this specifically. It is the only way to know whether you are dipping normally overnight and whether your current treatment is actually protecting you during the hours when protection matters most. I want to tell you about Dorothy, 73 years old, retired school principal from Cincinnati, Ohio, 11 years on blood pressure medication, 3 checkups per year, consistently good readings. Her cardiologist was satisfied. She was the kind of patient who does everything right. She came to me because she had been waking with headaches 3 or 4 mornings a week, not severe, just present. Her husband had mentioned she seemed restless in the early morning hours. A 24-hour ambulatory blood pressure monitor showed excellent daytime control, exactly as expected. Between 2 and 6 in the morning, her readings averaged 162/96. She was taking her antihypertensive at 7 in the morning. By the early hours of the following day, its effect had waned, and her blood pressure was rising into a range that sustained night after night for 11 years, had been stressing her cardiovascular system during the hours her doctor had never once measured. We worked with her cardiologist to shift one of her medications to bedtime. Within 4 weeks, her morning headaches had resolved. A repeat monitor 8 weeks later showed overnight readings averaging 124/76. She told me, "I thought I was doing everything right." I told her, "You were, but the clock was wrong and nobody had ever checked." Let me give you the evening routine that addresses all 5 risks I have described. This is not a complex protocol. It does not require supplements or special equipment. It is a sequence of decisions made in the 2 to 3 hours before sleep that collectively change the cardiovascular environment your heart operates in overnight. Finish your main meal at least 3 hours before sleep, ideally by 6 in the evening. Keep anything consumed after that point small, low in sodium, and low in saturated fat. This gives the blood pressure and triglyceride effects of dinner time to normalize before you lie down. Hydrate consistently through the day so that by early evening you are already in adequate fluid balance. A small glass of water as part of your pre-sleep routine is enough. Avoid alcohol in the evening. If you choose to drink, limit it to 1 drink and allow at least 3 hours before sleep. Keep your bedroom between /60 and 7/60 degrees Fahrenheit. Use blankets for warmth rather than raising the room temperature. This directly supports the nocturnal blood pressure dip and the cardiovascular restoration that deep sleep is designed to provide. Discuss the timing of your blood pressure medication with your doctor. Ask specifically about bedtime dosing. Ask about a 24-hour ambulatory blood pressure monitor if you have never had one. This single conversation may be the most valuable medical interaction you have this year. If you snore, wake up tired regardless of how long you sleep, or have been told you stop breathing during sleep, pursue a sleep apnea evaluation before anything else. And turn off screens 30 minutes before sleep. Not because of blue light mythology, because of the sympathetic activation that news, social media, and reactive digital engagement sustain. The cardiovascular transition into sleep requires moving away from that state. Anything that prolongs it delays and disrupts the protective physiology of the overnight hours. 4 things I want you to carry away from this. The most dangerous hours for your heart are between 2 and 6 in the morning. The habits of the evening determine what your cardiovascular system faces during those hours. The connection is direct and it is biological. Silent, non-dipping blood pressure may be the most important unmonitored cardiovascular risk in adults over 60 who are already on medication. A normal daytime reading does not confirm overnight protection. Ask your doctor about a 24-hour monitor. Untreated sleep apnea is not a snoring problem. It is a cardiovascular problem. It is the kind of condition that looks from the outside like a person who died peacefully in their sleep. And the evening routine I described is not complicated. Dinner timing, hydration, room temperature, medication timing, screen behavior, 5 adjustments, each with documented cardiovascular impact, each implementable tonight. You do not have to overhaul your life. You have to change the 2 hours before you close your eyes. Your heart works through the night without asking you for anything. It does not take breaks. It does not get to sleep. It cycles through the demands of every hour between midnight and morning, responding to whatever physiological environment the evening left it in. The question is not whether you care about your heart. You clearly do. The question is whether the evening routine you have been practicing for 20 years is the one that gives your heart what it needs to do that work safely. Now you know what those conditions are. Share this video with someone who always says they will focus on their heart health later. There is no cardiovascular event that warns you in advance that later has arrived. Subscribe to this channel because every week I come here with one purpose: to give you the information that changes what you do before it is too late to use it. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself,